of the dentoalveolar and non-dentoalveolar pathologies, and you will definitely develop a skill to see how to systematically see and analyze the CBCT images, what are the radiological signs of pathologies, and how to go about or how to read reports that can be communicated with all diagnostic information. Even you can be able to uh, get the judgment with high accuracy of how the pathologies are and how they are behaving, if they are aggressive, if they are uh, chronic in nature. So everything we are going to deal with it. So why radiology is important in maxillofacial surgery? Maxillofacial region is very complex. Everything is overlapping. There are much of the structures which are present in the face. So this is when we take a radiograph. Usually take a radiograph. They usually overlap, and we won't be able to get it in the way which we want, so that we can have a clear, lucid view for surgeries. So all the type of pathologies, being it simple to complex, they can have simple fractures to communicated fractures, cysts or tumors of maxillofacial regions, development anomalies, which will definitely will go give asymmetry to the face, and which requires sometimes require reconstruction of the structures. So again, radiology will help in great deal. So for planning of these kind of surgeries. Definitely, implant placements now is the uh, newer technique of replacing the missing teeth, and it is definitely a better option for than the traditional things. Also, it has been useful for TMJ disorders. So, how radio helps in it? Definitely helps in
Hi, sir.
diagnosis of.
Sorry
Yes,
to interrupt. Sir, slides are not moving actually.
slides are not moving.
No, sir.
Okay.
Please share the whole screen.
Thank you,
Yeah,
sir.
I've shared the whole window. Just I'll see you.
There will be three options. So please share again.
Okay.
First you stop sharing and then share again.
Now it is visible.
Please change. Yeah, it's visible now.
Now.
Yeah, it's changing. It's changing.
Okay. So the radiology definitely helps in diagnosis of the lesion, maybe how the lesion, if it is a cyst or a tumor, or uh, it also helps in looking for the extension of lesion. That way, how much is the extension, where all, what are the anatomical structures which are involved, or which all anatomical structure which are there in the vicinity, and while doing a surgery, we have to look for these structures so that patient does not have any post-operative discomfort. In treatment part, uh, radiology helps in pre-surgical planning. Nowadays, various softwares which have come, you can do all the planning, as Dr. Vinay yesterday has wonderfully explained about the dolphin systems, where they are doing all the planning of the all orthognathic surgeries or orthodontic movements which they want, and how the pre look will be there, and afterwards, after the surgery or after the orthodontic treatment, how the patient looks like, and if he you can also give the post operative photos to the patient, so that he can have that confidence or education of that particular treatment would be there. So definitely it helps in pre-surgical planning and during treatment. Yes, nowadays CBCT has been installed in things like radiotherapy. When you give a radiotherapy or C-arm, nowadays CBCT has been attached to the C-arm, where if during treatment, if they want to take any 3D scans of a patient, so they can take it very easily, because previously then they have to take the patient from the radiotherapy room from the radiotherapy room to the city room where they want to conduct a radiological examination, and afterwards they can come back to the radiotherapy. Now, because of its lesser, bulkier apparatus, they can easily installed on the C arm. Post treatment, definitely post treatment, they are very helpful in looking for all the things, like if there is fractures, if fractures are healed, they are adequately healed or not. Then in case of reconstruction cases, if the graft which is there, bony graft, if it is there, so bony graft, if it has merged with the original part, so they help in a great deal in the post treatment also. So what all radiographs which are there to see for any pathologies? These are plain radiographs, computed tomography, cone beam computed tomography, magnetic resonance imaging, ultrasound, and contrast and enhanced imaging. Contrast enhanced imaging, these are like arthroscopy or xylography. These are all where contrast has been introduced into the patient's body, and then imaging is done. Same thing if you do after, even there is after uh, taking a normal scan, like computed tomography, even contrast is also introduced in computed tomography also. So again, this comes under contrast enhanced imaging. So what are the plain radiograph which might be used during, yes, for a dentoalveolar fracture, IOPA, bite wings, or occlusal can be used for mandibular or maxillary fractures. Panoramic view, PNS view, posterior view, lateral skull, submental vortex. These are some of the extra oral views which can be taken during for a surgery when there was no 3D image, when there was no 3D imaging. What they used to do at the point to imagine the 3D is like they used to take two radiographs at 90 degree. One might they'll take PA view, and second they'll take lateral skull, so that they can imagine how the surgery, how the lesion is, what are the extension. They used to have some arbitrary kind of imaginations which on during on the surgical tables, which might not appear as they are on the radiographs. So this is very tedious process to imagine, and doesn't have give proper information about the patient's pathology. So this is the major drawback of a plain radiography. See, if they say a image, you are looking at as if plane is touching the wires, but in reality it is not so. And same thing, the beautiful woman is kissing the phoenix, but if that is possible, then there might be some flaw or error is there. Same thing, this is a building which have got two parts. One part is in the front and another part in the back. So in front view, what you can see is there is the pillar which is behind the front part. So if you go for a side view, then you can see that yes, there the pillar is in the behind, but they are connected in a straight way. This is a 2D radiography. Now again, if you have a third view, which is like aerial view or view from the top, so in that view you will be able to see that how the two buildings, like pillar and the first part of a building, are connected. They are connected in not a straight way. So this is all which is the drawback of 2D radiography. So that's why 3D radiography has been introduced. Now, major 3D radiography that includes computed tomography, cone beam computed tomography, magnetic resonance imaging, and positron emission tomography, which has been fused with either CT or MRI. There are variations which are there in computed tomography or MRI, which according to the need of a patient, you can do sequencing according to that. Depending upon the case, you can change the sequencing or what you want to see. So this is again gives a advantage to the patient as well as to the surgeon, so that they can look for all the possible parameters of a pathology. So basically we are going to deal in this presentation about CBCT. So right now I am directly switching over to CBCT. Other names for CBCTs are dental volumetric tomography, cone beam volumetric tomography, dental computed tomography, and cone beam imaging. When it was first introduced in 1982, it was preferred to be as a angiographic machine. Why they have given the name as dental volumetric tomography? Because at that time, uh, it was the only machine which could be seen as a machine which can take a volume of small area. The FOV, which is called field of view, that was very small. So that's why they have called this volumetric tomography. Like it can take tomography. Tomography means a slice. Imaging graphy means imaging. So it can take at a imaging of one slice only, and they have included volume into it, so they have called it as a dental volumetric tomography. But as the time passed, the they have improvised upon the machine, and now it has been changed to such a level that now it has been used as a mammography machine, or you can install it on the C arm. So they have given a very much changes into it, so that it could be beneficial to the patient. The main principle of CBCT, the cone beam, divergent beam, which comes out from the source, and it has been detected on the through the detector, which is 2D, two-dimensional. Whereas on CT, it is like a single array of detectors which are there. Here in CBCT, this is an area, like area which is there on the. If you everybody must have you must have seen the CBCT. You have seen like it is much more like a OPG machine, where one part which is having detector and another part is having source of X-ray. So it revolves around patient's mouth, patient's skull, and captures all the images. And afterwards, once it captures all the images, software does all the work, which gives you all the images which you can see it on the computer screen. Either it can be coronal section, sagittal section, or transverse section. So it gives you and also it can gives you OPG sections also, 3D formatted section also, multiplanar reconstruction also. So each and everything is done by software after taking data from the machine. So this is how a CBCT works, where this denotes the cylindrical part denotes the source, and the point part denotes the this thing detector, and this is the volume which has been scanned. This is called FOV, means field of view. So how it works? X-ray beams generally, when you throw a radiation onto a patient, the patient attenuates the X-ray beams, which has been detected. This is the normal thing across all the formats of the radiology. Then by through wires and all, raw data has been assembled by computer algorithms. There are very algorithms which are already set in the software, which process all the raw data which has been obtained from the CBCT machine, and generates cross-sectional component of the image called pixels. Pixels, if you can expand, it is called picture elements. PIX stands for picture, ELS stands for elements. This is pixels, you will call it in the two-dimensional view. And when this is again, if you want to see this thing, same thing in three dimension, that is called voxels. So voxel is a volumetric data. Uh, I think all of you have seen the digital pictures. If you enlarge a picture to an extent, then you will find some kind of square boxes which are there. So these boxes are generally called as picture elements. And the third dimensional component of this pixel is voxel. So image acquisition is like OPG machine, it rotates around the patient's skull. So during rotation, I think around 500, 600 scans which are taken at a regular interval. Like if you can see it in this image, this is the position 1, X-ray source which comes out, and it is the detector source. Now this moves around, it takes another shot, it moves around, it takes another shot. So all in 360-degree, it takes around 500 to 600 shots. And this is basically called projection data. जो हम पहले बात कर रहे थे, that data, raw data. So this is called a raw data, which is being now processed by computer softwares. So during 360-degree rotation, it takes around 500 to 600 uh, scans, so that they can compile all the data and can be presented in form of in form of things which can be interpreted. So now, what are the differences between a cone beam CT and a multi-slice CT? Yes, there are differences between cone beam CT. That's why cone beam CT has become a popular thing as compared to multi-slice CT as far as dentistry is concerned. So cone beam CT is like image the whole area in one rotation, then reconstructs the slices, image the patient in multiple slices. Now what that means is, just a second, even I have it means uh, it takes volume first. Now when it rotate, I am talking right now about cone beam computed tomography. It takes around 500 to 600 basic images or projection data. Then they compile all the data and form a volume out of it. After making a volume, it then software constructs multiplanar, like you can get transverse images, sagittal images, and coronal images. Now, in a case of multi-slice CT, it takes only transverse images first. Transverse images are the real images. They take transverse images first and then stack one over another and make a full 3D view. Afterwards, coronal and sagittal are reconstructed ones. In cone beam CT, all the three are reconstructed. However, in multi-slice CT, it is only sagittal and coronal images which are reconstructed. The geometry of beam in cone beam CT is definitely a cone shape, and whereas in this one multi-slice it is fan shaped. Dosage is very much less as compared to multi-slice CT. Dosage is around, depending upon the make or manufacturer, it ranges about 45 to 477 μsieverts, whereas it is up to 2000 μsieverts in multi-slice CT. Operating voltage is more or less same. Now focal spot, everybody must have read about focal spot. Focal spot, if shorter the focal spot, better is the picture. So it has got few short focal spot as compared to multi-slice CT. Now radiation dose is less, then obviously the annual background radiation dosage is also less. Definitely that runs up somewhere. The cost is very less. Cone beam CT comes around like 40 to 50 lakhs. That goes up to 1 CR. Spatial resolution is very good as compared to CT scan. We'll explain you why afterwards. You can see 0.07 to 0.4 mm line pairs per mm. Line pairs resolution is always measured in line pairs per mm. Resolution is like if you can, how much close the two line pairs are placed, so that you will be able to see those two lines very much clearly. So as far as CT is concerned, it is 0.3 to 0.4 mm. Sections are not skipped and no loss of diagnostic information. Now what that means is, when you do a CT goes in a spiral way. So if it takes one round, round, then it moves a bit like zero point 0.2 to 0.3 mm away from the present point, and then again take a one more. So zero point 0.2 to 0.3 mm, which is it moved. That is called pitch of the CT scan. That information is lost. So after getting all the data from the CT scan, they used to reconstruct or rebuild this information. So there is a loss of information in CT scan. Now, one of the most major, what you can say, is the disadvantage of cone beam CT is soft tissue imaging. It is not as good as what you can find it in the multi-slice CT. The soft tissue have got better contrast because of its working, because of its algorithm which has been used, because of the type of uh, mode in which the picture has been captured. Soft tissue imaging is not good. Voxel dimension depends upon pixel area on the area detector. So what I have told you is like in CBCT, we used to take volume first, then we can divide it in anything like the coronal, sagittal, or transverse. Now, voxel size depend upon the pixel size on an area detector, means that you can cut it into as thin as 0.25 mm slice thickness. You can get that much of slice from a CBCT. Whereas in multi-slice, it all depends on slice thickness which you have already decided. जो 2 to 3 mm that has moved, the gantry which has moved, उतना एरिया से कम हम उसकी स्लाइस थिकनेस नहीं रख सकते. Voxel resolution is isotropic. Now, in another picture, I'm going to show you what is isotropic and what is anisotropic. Isotropic means voxel is a 3D structure where x is equal to y is equal to z, means that is in form of a cube. Whereas anisotropic is x is equal to y length is not equal to z, means that is a cuboid. I'll tell you afterwards. Next picture will show and explain everything. Uh, Again, cone beam CT, the next disadvantage is poor contrast resolution, whereas multi-slice CT has got good contrast resolution. The spatial resolution of cone beam CT is very good, but contrast resolution is not as good as CT scan. You can't do cone beam CT for malignant conditions, because you will not able to find the involvement of lymph nodes which are there, because it has got very bad at soft tissue imaging. Definitely multi-slice setting is the option for malignancy and all. Reduced artifact from the dental radiation restorations, yes, because it gives lesser amount of radiation, it has got lesser amount of artifacts from the dental restoration. It is good for implant imaging, gives you lesser dosage. If same thing has been done with multi-slice CT, it will give you more dosage to you. Now this is a isotropic and anisotropic. Isotropic is what we mean is x is equal to, if that is the area. If you want to, this is the FOV which we are going to do, and this is the area. So x is equal to y is equal to z. This is like isotropic. Anisotropic is x is equal to y but not equal to z. So this z will give you the picture of how much gantry has moved, because it all depends upon slice thickness. So it can't be equal to the, because it can't be equal to all the dimension can't be equal. So voxel size in this one is isotropic, and in CT scan it is anisotropic. So that gives you image of 1:1. How you see it on the patient, definitely the image which you see it on the computer or computer screen, it is equal in size. Generally, softwares are used to get all the data, and you can convert it into all the three planes which are there. So this is basically how this works. First, you take one basic image, second basic image, or third basic image, fourth basic image, fifth basic image. Now this is all the thing which has been done on the machine. Now second picture will show you how it has been rebuilt on the computer. The data from first one, second one, third one, fourth one, and fifth one. That gives you again data. So this process is called back projection, because you are getting what all you are getting from the original data is been back projected on in the computer, and then you can get a real image. So this is called back projection. So how what are the types of machines which are available in markets are supine machines, standing units, and seated units. Supine machine, yes, they are generally good for patients who have got trauma, who doesn't sits up, or ambulatory patients. But it requires a large surface area. Standing units are good, but again, patients with trauma or patients on a wheelchair get some problems, so that because a machine cannot pull down to that much low in the level. Seated units are comfortable. Again, who has got trauma or ambulatory patients, again they have got a problem in this seated units. And one of the important point which is there is like immobilization of patient's head is of uttermost importance. Otherwise, you will not get any good pictures or radiographs. So this is a supine machine which we had earlier in our department. Now it has been decommissioned. This is one with Kodak, which is there in our department. Is Kodak 9300 CS. CS. This is now upgradation of again this machine has been come, that is 9600, which have got artificial intelligence in it. This is from Plan Mecha Promax 3D. This is for small FOVs. This is for full FOV. These are all machines which are available in the market, and this is a sitting one. This is a supine one. This is with nowadays they have gone for with CM if you want to add it on the CM. Scan volume. This has been diamond measured as field of view FOV. So this is measured in diameter and height. It is a cylindrical shape, and you can different manufacturers have got different FOVs ranging from 5 into 5 up to 15 into 15 mm. Sorry, centimeter. Scan volume. Scan volume, it all depend upon detector size, geometry of beam projection, and collimation of the beam. Detector size is what you have minimum got on a detector. If it is like it all depends upon depends or differ from manufacturer. ICAT, Kodak, then Scanora, all they have got different detector sizes. So again, scan volume is different for all the machines. Geometry of beam projection is same and in every machine, like it is a cone beam only. And collimator's role is also that how much beam it can throw it on the detector. So again, that is a limiting factor when you decide a scan volume. These are all scan volumes which are present in our machine from 5 into 5 centimeter. This is for single arch, 10 into 5 centimeter. Again, 17 into 6. Basically, we use it for TMJ. Dual arch is 10 into 10 centimeter. If you want to take both one, sinus view, if you want to take only sinuses, then it is 17 into 11. And if you want to take full volume, that is 17 into 13 centimeter. So these are all indications of each and every pathologies. If you want to see, this is how it looks like in a full scan volume. This is for sinus view, for chronic sinusitis. This is yes, nowadays it has been quite used in ENT patients also, where you want to see cochlear implant or middle ear. So this even the bones which are present in the malleus, incus, and stapes, which are present in middle ear. So it can also be seen for osteosclerosis, cholicosteatoma, superior semicanal dehiscence. So all these things, which you can see it right from chronic otitis media. Again, nowadays CBCT has been preferred. So these are all the things which you can see, or FOBs which you can see it on the CBCT machine. Now we have seen a source part. We have seen how it has been made from projection data and all. Now, what are all detectors which are made up of? Either there are like majorly there are two detector types. Nowadays, it has been added one more type. One is image intensifier plus charge coupled device, that is CCD. CCD based. Second ones are flat panel areas, and third one nowadays, which are now coming, that are CMOS based. So complementary metal oxide semiconductors. The same thing happens in the detectors are there, which has been lined on the both the sides with the skinty layer. In this case, they are made up of cesium iodide. Likewise, we in plain radiography we used to put for X-ray radar, we used to put a X-ray inside a cassette where both the sides have got something which converts X-ray into light source. Same thing does for cesium. Same thing cesium iodide does for CBCT. Now, detector, the quality of detectors must be able to record all the X-ray photons, read off, and send signal to the computer. Be ready for next execution as early as possible, because there are hundreds of scans which are running at the same time. Like if you are going to take 600 images in like 18 to 22 seconds, so it should have really a fast speed, so that fast speed of clearance of data from one image. Now reconstruction. Reconstruction part is been done by with the help of software. Each and every company has got their own software. Kodak has got own software. iCat has got their own software. Each and every software have got mild differences which are there nowadays. Third-party software are also available for viewing and all. Like yesterday what Dr. Chug has told you, that is what we called is as a third party software, because it only processes the data which has been extracted from the scans. So it constructs all the data like with back projection method and show it on the screen. So after reconstruction, you can see all the planes which are there. This is transverse section, coronal section, sagittal sections. Again, these are all the sections. After that, you can see MPR, multi-planar reconstruction, which is panoramic. Panoramic sections can also be made out of it, like OPG, which is there, can be made out of it. And the beauty of this CBCT is like you can take the, you can view the sections on OPGs also. So OPGs also you can see a different section. Paraxial section you can see it on the CBCT without any giving another set of radiation to the patient. After stacking whole, this is the 3D volume which you can see after getting all the volume. This is how a 3D picture looks like when initially it has been uh, volume rendered. But what I'll suggest you is like 3D pictures are not reliable for the information or for the diagnosis of the pathologies. Always use all the sections because they are more clearer, they give more information, and because in this 3D pictures, some part is been reconstructed and remade from the information or rebuild it, which is not actually present in the patient. And sometimes noise is also there. So yes, definitely this is not the thing for diagnosis of the patient. You should look for each and every section for diagnosis of a patient. Now, how will you view a CBCT? Right. DICOM, it is an called as digital imaging and communication in medicine. This is a like a language which is been which CBCT used to speak. You can remember it like that. And same DICOM like JPG, TIFF. This is again a language of CBCT. You can transfer, store, visualize all the images in DICOM only. Uh, Majority of the third party software, they are compliant with DICOM systems only. There are other systems which are also present like PAX is uh, uh, packaged packaging and archiving. Again, one more is there like VNA, that is virtual neural communications, VNC, sorry, VNC, virtual neural communications, but they are not as popular as DICOM, because DICOM is compatible with almost all the software, planning software which are there, and it is easy to transfer also. Even if you get have a pack system with you, so each and every department, like if radiology will have got different pack, surgery will have got different pack system. So you, if some wants to search a data on a total system, so he has got to search it on the pack system of radiology. Then again he has to go to surgery packs and search again for it. But DICOM, they can be searched on a single system where all the systems are connected. So DICOM is a normal language which CBCT talks. So what are the advantages of CBCT in dentistry? Being considerably smaller, CBCT equipment greatly reduce the physical footprint. ज़्यादा जगह नहीं चाहिए. You don't have require much of a area for to install a CBCT. Cost is very much less. It has got highly contrasting. It provides imaging of highly contrasting structure, therefore particularly well suited for imaging of osseous structure in the craniofacial area. Yes, they are only good for osseous structure only, not for a soft tissue. They have got rapid scan time. Beam is very limited. Again, beam is limited, gives you lesser radiation dose. Image is very accurate, like 1:1, reduced patient radiation. Interactive display mode, you can play around with all the images which are there. It is very easy to go. Once you have to sit on the console system, and like after 2 or 3 days you will be like masters in this one. You can get multiplanar reformation and volume rendering. Limitations, as I told you, poor soft tissue contrast, artifacts which are there, and image noise. I am dealing a bit about image artifacts which are there, so that you will be able to see that if something where all things went wrong. So artifacts can be divided into patient related, acquisition related, cone beam related, and scanner related. Acquisition. Now there is something, a beam hardening term, which all of you must have listened about or heard about. What is beam hardening? Beam hardening is something like if while traveling of X-rays to the patient, if X-ray beams encounter a heavily restored tooth, so all the radiation, low energy radiation which is there, which will be absorbed by that filling. Then all the high energy X-ray beams get out of it and cast an image on the detector. Now the resultant beam which has come out of the filling will be having much of a higher energy as compared to the beam which is striking the filling. So that is called beam hardening. Means beam has got hardened. Actually the average energy of a beam has increased. So I have already told you that computer assembles all the things and show it on the screen by the way of back projection method. So when it goes for back projection, then you will have a cupping artifact or a streak band of streaks and dark bands, depending upon the type of or shape of the hardening filling which is there. So this is an example for streaking artifact. See how the streaks which are emerging out of the this thing. If it is cylindrical, the filling is cylindrical, then it will form cup shaped defect. If it is irregular in shape, then it will form streak and dark bands. These are the streaks, and adjacently there are dark bands. So it is always advisable to if something is there, avoid the filling, reduce the FOV, or modify the patient position. This is in older machines. Nowadays, newer machines have got something different kind of algorithm known as iterative algorithm, which used to mask all this uh, highly radio opaque things, or highly radio opaque bands. Like if in case of, if you want to see like surgical cases where uh, plate has been placed, so it will give you cupping or streaking bands effect. If you want to avoid it, avoid either do on a different patient position or reduce the field of view, or you can still use iterative type of algorithms. This is patient-related artifacts are generally by motion, unsharpness which is there, blurriness which is there. If patient move while taking a radiograph, that's why I have told that stabilization of head is an important factor while taking a radiograph. So therefore, there is one cephalostat is also there to stabilize the head also. But generally, patient should not move while taking a radiograph. This is the blurring. If you can see two images in here, two images. Again, this has been patient has moved, so you will get sharp, unsharp image. This is while deglutation. Aliasing artifact or a Moir pattern. Can see it here. Like there is a streak of bands which are there on the periphery of the image. These are called aliasing artifact or Moir kind of artifact. Why this happens? It is due to the cone shape of a beam. More rays which strikes at the initial part of the structure, and when it comes out of the another part, the lesser number of rays which are recorded. So this gives a type of, this is again artifact which has been caused due to cone beam shift, and it can be uh, removed with the help of now softwares which are there. This is called Moir pattern, because you can't see here. So the patient must be having a radiation source from this side and the Moir pattern on this side. Again, this is a Moir pattern. You can see the accentuation of all the Moir pattern on the periphery of this, whereas this area is not that much affected by a streaking. Image noise. Image noise is a variation in the number of X-ray photons in the beam as it exits from the point. So it can be detected on the image detector with as a grainy or mottled appearance. Now I'll show this picture. If you can see this picture, this has got grainy appearance, and this picture has got lesser amount of grainy appearance. Why there is a difference between the two? Because we have increased the voxel size. See, this is for 0.076 and this is for 1.3. So definitely, if graininess is present in the picture, you can increase the voxel size and the diagnostic information. You will lost on the part of diagnostic information if the voxel size has been increased. So voxel size definitely reduce the grainy appearance, but again, diagnostically it is not good. And these are the scanner related, where there is indentation on the detectors which are there, result from imperfection, or if calibration is required and non-calibrated detectors which are present, you can see this kind of artifacts which are there. This is some damage to the detector which has been present, or again a ring artifact which has been called as cone beam related artifact. This is there are two types of cone beam related artifacts. One is partial volume averaging. This is partial volume averaging. Suppose you are want to get you are doing acquisition of a radiograph where this voxel have got partially exposed with the image. So this voxel have partially been exposed. So the averaging which it will show it on the computer will see it as a radiopaque mask with the light bands. So this you can improve it upon when you want to. You will get voxel which has been exposed with full radiation. Then it will be look look at the green object metal. The beam does not see it in all the position. The inconsistencies between the view causes shading artifact to appear in the image. If voxel is been exposed partially, then so how will you remove that one? Select as small as voxel size as small as possible, so that all the voxel size comes under the scan of X-rays. Undersampling is, if you now previously, nowadays all the this thing, all the CBCT machines have got 360 degree of rotation. Previously it used to be 270 degree only, so you will get half information. That is called undersampling. The number of projection bases were less as compared to which are there in 500 to 600 in our machine, which have got 360 degree rotation. It will be very much less in the 270 degree rotation. It is somewhere around 200 to 300. So definitely less amount of data, less amount of resolution, less amount of uh, sharpness, and lesser amount of information which you are going to get. This is from lesser. Again, if you rotate more, then again you will get much more information, and this is with the maximum information. Cone beam artifact, you can see it, because here if you can see, this is the cone beam artifact. So because the rays will come like this, when it moves in other direction, it comes like this. So again, same IOP, if you can call it as a cone cut appearance. Here it has been called as cone beam defect because of radiation of the air. Also you will have a cone beam defect. So it results in image distortion, streaking artifacts. To minimize positioning of ROI is region of interest in a horizontal plane. So if you can see, what you can see is a couple is looking at the sea face, but another way of looking it at is, this is a picture of a small kid or a neonate. So it is generally perception which we want to see. I have included some of the images of maxillofacial pathologies. Just we'll run through it. This is for implant imaging, where we do implant dimensions and in dimensions in superior, inferior, buccolingual, and mesiodistal. You can see all the three planes in a single section. Nerve tracing, you can see we have done a nerve tracing here. We used to mark it at every basic projection, and then it rebuilds it on the computer, and you will see it as this whole nerve which has been tracked. You can see get it in the implant one. For the third molar infection also you can do nerve tracing, and even you can find the distance from the nerve also, distance of the implant from the nerve. This is for trauma cases. This is the zygomatic arch fracture. You can see it on the three planes, which helps surgeon to reconstruct it in a much better way. This is for cyst, dentigerous cyst, which is there. You can see it in all the three projections. This is AOT, adenomatoid odontogenic tumor. This is some sort of malignancy which is there. If you can see, there is less of a expansion, but more of a destruction, which has been evident on this one. But still, actually, first we have given the diagnosis of ameloblastoma looking at this picture, but it turns out to be a malignancy, because this gives a soap bubble appearance. This is the reformatted panoramic, which I have told you. You can also do a lateral cephalogram with all the angles which are there. That automated report has been generated for the type of analysis which we want on the for the patient. So it does all that also. 3D printing, yes, 3D printing. It is now a newer technique. The basic of 3D printing is getting information from the patient. Now, information from the patient you will get in two forms, either from the X-ray and from the photograph, a good photograph. So all the 3D data which has been there, it has been given it has been diverted with the help of DICOM to the third-party softwares, which does all the image processing, and the third party software can be mimics, Katia, materialize. All the software are present in the market nowadays, and then they can do the 3D printing and gives you a model or a surgical stent or a implant also. So again, this is the getting a right amount of data from the CBCT is of par importance. Without it, if the data is not good from the CBCT, then definitely the quality of the finally printed product will be very bad. So again, 3D printing is a type. 3D printing is a application which uses the data from CBCT. You can also use the data from CT scan, but given the radiation dose and accessibility and ease of doing, yes, CBCT is far much better than CT scan as compared in the cases of osseous reconstruction only. Thank you. Uh, with this, I'll complete my presentation. If you have any questions, you can ask me.
Thank you, Dr. Vikram, for a wonderful presentation.
Yeah, thank you, ma'am.
Do we have any questions from the audience? I request the participants, they can drop their query in the chat box, or they can
Yeah.
unmute and ask. We have a small group, so we can discuss live also. I think no queries.
I think everybody has understood my lecture.
Yes, absolutely. Nicely presented. It was nicely presented.
Thank you, ma'am.
So we don't have any discussion points. So we end the day's session today.
Yes.
We'll meet again tomorrow, 5 p.m. for the next session.
Okay. Thank you, ma'am. Thank you, everyone.
Thank you. Thank you.